specialty surgeons, colonic, acute care, bariatric surgeons, and specifically what we'll talk about today is advancements in esophageal stricture management, both benign and malignant. If you guys have any questions, I know it's early, feel free to throw up a hand. We'd love to see your input on what you see and what you have seen continuously with like the variations in the specialties. And again, if you have any questions afterwards, we'll kind of go over an esophageal stent. I know if you've worked with any of the physicians that I mentioned, you probably have seen some of these, right? Show of hands, anybody work specifically with CT, bariatric, anybody? Okay. Everybody, who you work with? Bariatric, so Wheeler, Ganga, those guys. So you probably have seen the esophageal stents and all that. Anybody work with CT? MIS?
They're in another meeting.
Oh, okay. So this may or may not be pertinent to what you guys do. So just have to do the housekeeping thing where I tell you that this is stuff that we're going to go over because this is in coordination with one of the devices that we use in these procedures. We'll use a Boston Scientific product because we have it here. And so again, you get C&E credits for this. Usually they take about 2 to 3 months to get in, so I'll get those sent in. Well, there's supposed to be a questionnaire rating me 1 through 4. I'll go ahead and give myself a 4, which is the best. So I appreciate it in advance. Just so you know, this is Garrett. Garrett's gonna be out in San Diego. He's riding with me this week, so he's just here to keep me on track. Bless you.
I got a babysitter this week.
So I'll try not to read to the slides, or I'll read to the slides, not read them, so keep you guys awake. So basically we'll go over benign esophageal strictures, the treatment options for those, causes of those, and then the malignancy as well. You guys know mouth, pharynx, esophagus, this is the lower anatomy, what we're going to be working with specifically today. It's talking about this portion of the body, right? So esophageal wall can consist of, really what we worry about is 4 of these layers. So there's the mucosa, submucosa, the muscle layer, and then the serosa, right? Most of the disease states that you're going to see are going to be in the first 2 layers, mucosa and submucosa. But in the instance of malignancy, it gets down into that deeper lining. So stage 2 would be in the deeper lining, getting into the submucosa. With stage 3, you'll see it invade into that deeper wall, so the muscle layer, and then stage 4 will be growing through to nearby, basically metastatic, right? So it's going through that serosa layer. You know, the muscle layers, as you can see, it's striated muscles for the top third, and then it starts to get into that smooth muscle as it goes into the stomach area. So, dysphagia, right? When a patient comes in, they're having trouble swallowing, or they're having some kind of stricture, doc, how are they present? Well, they've got dysphagia, they're having trouble swallowing, they're regurgitating food, they can't get things through. So, really, what is the main cause of having dysphagia? So, strictures mean intrinsic, which means you can actually see them. Most of the time, it's a malignancy. You can see it's a big, friable, bloody mass. Extrinsic, so a lot of times if you're talking about the mid-esophagus and it is a malignancy, you can have tracheal or lung cancer that's kind of impinging from the outside in, or it can be disease related to like a stricture caused by peristalsis, right? Anybody know any of the peristalsis related strictures or the main disease state that you guys work with? No? Like echolalia, which is a neuromuscular, so basically it's like a jackhammer esophagus, or really that LES, the lower esophageal sphincter, just doesn't relax, so they can't normally process food into the stomach like they're supposed to. So let's talk about benign esophageal strictures, right? So about 800,000 plus per year have issues, right? So what's the main curative treatment for, right? With dilation. Anybody work with dilation balloons, the CRV balloons that we went over, right? Out of those, how often do you see the same patients coming back? A lot.
Mm-hmm.
You say like the same patient multiple times per year, multiple times throughout 2 to 3 years. What's an average?
I would say a couple times a year.
2 to 3 times a year? Yeah, it's pretty.
Like once a quarter, maybe.
What's it?
Maybe a little over once a quarter.
Yeah. So, do they get better? And is it usually a graduative?
The one ones I've experienced don't, I mean, they, get better for a limited amount of time and then it just strictures back down.
That's the unfortunate thing, because a lot of times that scar tissue becomes fibrotic, and basically we're trying to stretch or break it out. And a lot of times what the physicians will do is gauge what the stricture is initially, and a good way for them to do that is by using the scope, right? If you can get the scope, an EGD scope through, which is about 9.86 millimeters, hey, if it's tight, I'm going to start with probably a 10, 11, 12 balloon. If they can't get it through, if it's a real pinhole stricture, most likely they're going to start with like a 6, 7, 8, or 8, 9, 10, because they don't want to bust it or basically break the stricture up so bad that they cause a perforation. So they usually start, because the rule of 3, which was invented by physicians, just indicates you shouldn't dilate a stricture more than 3 sizes in one setting. And the reason why, it's just safe. And a lot of times that's why you'll see these patients come back multiple times, is because they're gradually dilating it up. So, lost my train of thought, but yeah, they'll gradually dilate it up. So, does anybody, just off the top of your heads, know what the minimum size of the esophagus needs to be prior or to have normal digestive function? 18 millimeters. So the average human esophagus goes from about 18 to 22 millimeters. So if a physician can be confident in getting the stricture up to 18 millimeters, most of the time that's good enough for them, right? If you had a gradual, they come back once a quarter, and they go from 8, 9, 10, 10, 11, 12, and they can get them up to like an 18. Usually that patient's going to be okay, because that's what the body needs that stricture to be open to just function normally, right? They may have reoccurrent issues, but at the same time, they should be good to go from that side. So here's the big list of esophageal strictures, right? Is there anyone that jumps out that you see probably more than the others?
Anastomotic.
Anastomotic, okay. Anybody else? Barrett's. Yeah. Barrett's is a big deal.
I see a lot of food infections.
Food infections? Yeah, most people wouldn't think like a food infection, but when you get whatever reason, maybe they just didn't chew their food right. Yeah, radiation. That food will sit in there, it irritates. Just like anything else, if a foreign body sits in your esophagus or anywhere too long, it starts to irritate, and then the body starts to stricture it down, right? Because they look at it as a foreign object, they don't want it to go through the normal process, and then you start getting the stricture. Who loves coming in for a food bolus at 2 o'clock in the morning? Not seeing anything. Yeah, perforate, and then you got it.
Those are lovely.
You love it, so call you when they got a food bolus.
All the
Who
time.
is that?
The one with the green hat, she loves food bowls. So call her. Because there's just not a really good tool.
We'll put her on that call
to get
team.
those food bowls done, right? They're a pain in the butt, and they usually take an hour, 2 hours, right? But all of these can cause the strictures.
Especially if it's chicken.
Yeah, chicken. So it just fries, or it's just a little friable, and you just pick it out forever. And eventually you can push it through.
Just shove it down.
So like Barrett's esophagus, that's a really big issue. Anybody know what causes Barrett's, or what they think leads to it? They don't know for sure, but a lot of times it's the main cause. Yeah, GERD, right? Just reflux all the time. So when I first started 6 years ago, I understood that esophageal stricture, esophageal cancers came mostly from drinking and smoking, right? The 2 things that people love to do cause esophageal cancer. Now it's more related to GERD, because 2 things, right? The food that we eat, we have a lot of reflux, and then really what happens is people get hiatal hernias, because as humans we just have poor posture. So we're sitting down, we're eating on the couch a lot. I'm guilty of it too. I ate my dinner on the couch last night. So when we sit down and eat, the body processes the food normally, and that diaphragm tends to come up, which pulls the esophagus up in the stomach, and it doesn't keep that LES down, which you get reflux, acid, and then you get stricture. So all of these are big deal, and cause the benign strictures. So peptic strictures, right? Those are usually caused, you heard peptic ulcers or gastric ulcers. Peptic just means anywhere through, like from the GI tract that you're going to see through the duodenum, stomach, or the esophagus. the most common type of it, because mostly GERD, right? GERD, acid reflux are going to cause those strictures. Esophagus gets irritated, starts to stricture down, right? So that's where you're going to see a lot of those dilations come back and forth. So what do? We dilate, right? So balloon dilation has become kind of the gold standard of everything, right? Because from that previous slide, as you saw, the strictures aren't terribly long. The normal human esophagus, whether you're 6'4", or you're 5'10", or 5'3", is about 22 centimeters in length, right? So the strictures 1 to 4 centimeters are pretty focal in their presentation. The most important thing you want to do is you don't want to perforate, right? So you want to be able to see. The advantage of a balloon gives you the opportunity to do what's called balloon endoscopy. So you can look inside the stricture or in the balloon while you're dilating the stricture, and what you're looking for is that mucosa to have a blanching or a whiting, and then you want a little bit of hema, right? Like you want these red squiggly lines, which means you're actually dilating the stricture. You're starting to break that stricture up in some of the blood vessels, but you're not, perforating it, where it looks like somebody just took a razor and sliced the esophagus out. So that's why it's really important just to use a balloon. You can see what you're doing. You pull back, you get those 3 levels of dilation into one setting, and you go from there. Unfortunately, for patients that are continuously having strictures or refractory benign, the other options are repeat interventions, which are what they are. You can do a stricture cutting. Has anybody ever seen those before? Where they'll go down with like a needle knife and they'll do little cuts, like if it's a Schatzky's ring, unfortunately, where it's fibrotic all the way around. They make little cuts with a biliary needle knife, and then they'll balloon dilate to hopefully break that stricture up. You can do surgery in the worst case scenarios, like an esophagectomy, or you can do self-expanding metal stent. Right? Self-expanding metal stents are not indicated for benign usage, even though, well, technically there's one usage, TE fistulas. The FDA, our buddies, haven't given us the go-ahead for removability, even though most physicians, and if you've seen any bariatric cases, you know that you can remove them probably 6 to 8 weeks, right? So, Schatzky's ring, again, a ring located at the lower esophageal sphincter. Usually it's pretty definitive. Like I would say that's not representative of what we usually see. It's usually more white, more defined for that fibrotic tissue. Dilation, that's an example at the bottom, a catheter where a little needle comes out. It's about 5 millimeters. You just make little cuts, dilate it, and go from there, right? It can be caused from congenital defects, injury due to GERD, or ingestion of caustic materials, or you can actually get it from the food bowls, this food, right? Intermittent dysphagia is the main cause because patients present with these skin swollen. So anastomotic strictures. This is the big one, probably here because you all are in academic tertiary care, so you're probably going to see more of those than some of the others. So again, you've got a mass, cut out healthy tissue, and get good clean margin so the patient's cured. Challenge is when you put 2 lemons back together, whether you're stapling or suturing it together, it's scars, right? Anywhere in your body, whether you get stitches or anything else, when you put healthy tissue to healthy tissue, unfortunately you get that keloid and it scars up, which can cause strictures again. Typically, what do you all see for these anastomotic strictures? Anybody who sees them? You do. I'm going to pick on you because you responded earlier.
What do you see?
What do you see the physicians do for the treatment of these? Dilate? Are these some of the patients that come back all the time because the stricture just comes back, or would you say 1 or 2 dilation works?
We'll dilate a couple times, and then a lot of times we'll just resect it. Just do a
Revision of the resection? Yeah, those are options too. Balloon dilate, esophageal stents, right? Those are really the options. So here's a big one, right? You probably see more of these than anything because I know Dr. Wheeler and Dr. King do a lot of these surgeries. So the issue with the gastric sleeve, one, it works real well, but you're taking off a huge chunk of this stomach, and you're taking off a lot of the fundus. Most of the strictures are gonna happen in this incisor right here, but also they can have post-anastomotic leaks, and then these strictures up here. Fortunately, you're changing the natural anatomy of the body, and then you get strictures. Anywhere, again, that you're making staple lines or suturing, it's gonna scar down and you get strictures. So a lot of times we'll use fully covered esophageal stents, leave them in for a couple weeks. Basically what it's trying to do is remodel that lumen. So when it starts to grow back, that stricture, instead of having to dilate constantly, it just grows around. The idea is to grow around that stent that has good radial force and keeps it open. Same thing with the gastric Roman wire, the bypass. Again, right here in this area, you're connecting some things, suturing, stapling, lumen scars down. You have to have something to be able to keep it open for a while in a remodeled area. Just a quick question, not to get off track. Are you seeing the physicians do more gastric Roman Ys or bypasses over the last 2 to 3 years than sleeves? I know it was like 80% sleeves, and then the gastric Roman
I say it's 50-50 now.
50-50? Wow, that's good. That's probably up a lot in the last couple of years, right?
It just depends on the patient, what's best for them.
What's the main reason you hear patients get bypasses versus sleeves?
Well, yeah.
Diabetes. That's the main one.
Well, also, some of them have a lot more weight to lose than others.
So BMI is a big, plays a big deal.
Very big, yeah.
Are you seeing more gastric sleeves get revised in the bypasses? You see those ever?
No, not a lot.
No? Okay. I'm seeing that a lot through, my territory spans from Springfield, Missouri, up to Springfield, Illinois, and everything in between that, and southern Illinois. So we see some gastric sleeves get revised in the bypasses as well. So achalasia, that's that neuromuscular. So literally the esophagus just doesn't relax, so they can't pass food. So we'll do a manometry, which just measures the level of pressure that the esophagus actually has. If it's under a certain level, then they know they have to do something.
Did you page blue?
So anybody do or involved with surgeons that do Heller myotomies? Like that? Who? Dr. Rawlings does? Okay. So Heller myotomies, laparoscopic surgery is kind of the gold standard, right? The challenge, the limitation, I guess, is the grade of achalasia that I have. If it's grade 1 or 2, laparoscopically you can still get up pretty high into the esophagus. When it gets to grade 3, which is it starts about 14 to 15 centimeters up in the esophagus from the LES, that's where you have to do more invasive procedure. So in endoscopic, there's, and we don't make anything for this is just me telling you guys what to do. POEM is perioral endoscopic myotomy. So this is what is done for those higher. So basically they go in, they make an incision into the mucosa, they tunnel through the submucosa with a scope, go all the way down to where they start seeing the gastric muscles right below the LES, and then on the way back, so they tunnel down, and on the way back they cut the muscle on the way up. Let me do this here. I think maybe the GI guy does it. Ganga's gonna be doing it? I always do a poem, or a G poem, right? Or POPs, right? Peroral, pyloric myotomy. Yeah, no, so the G poem is basically the same procedure, it's just at the pylorus, right? You get peristalsis or at the pylorus. A lot of times you can dilate, you put stents in there, but it never gets any better. So what you do is you just tunnel in, you cut the muscle around it. So now, instead of it not relaxing, there's no muscle basically to even constrict. So go through with a cap, again, cut it with a needle knife, go back, and then you just flip it closed. Patient should be good, right? And this is mainly for like jackhammer esophagus or grade 3 achalasia. So alternative therapy approaches, you can do metal stents for achalasia. Unfortunately, because that muscle just doesn't relax, the remodeling of it just doesn't work really well. You have to do an invasive procedure, minimally invasive through the scope, to actually solve the problem, just cutting the muscle around it. So let's talk about malignant, right? Esophageal cancer. In 2008, which I know this is kind of old data, almost 17,000 cases. Unfortunately, close to 14,000 deaths, so that's pretty high. It's about 80% death ratio. Down here, you'll see the survival rate by stage. You know, if you have 0, which is in situ, right? Now they have devices you can do endoscopically. If you can find a little nodule and get T1A, T1B, you can actually resect that. You suck the nodule up into a cap, you band it, and then you snare it off. Make sure that you've got clean margins around that lesion. Patient's basically cured, and then surveillance steps out. Stage 1, usually resection. 2, 3, and 4. You know, obviously the survival rate for those is not really great. The good thing that is come about with the radiotherapy, I'm sure you all have seen that here too, is that the radiotherapy now versus 5 years ago, radiotherapy is really good. It basically melts these esophageal tumors away. In the past, the challenge was the radiation restrictions, right? It's really good at frying those tumors, but it also fries the mucosa around it, so you stricture now. The advancement is that the new radiotherapy has reduced the amount of stricturing that they get from that radiation, so it's kind of a win-win for everybody. Shrinks the tumor, they don't get the strictures that they used to. And I thought this was kind of, you know, African Americans, unfortunately, colon cancer and esophageal cancer, they're about 50% more common, and then 3 times more likely in women, or men than women. So, guys.
And the cigars.
2 types of esophageal cancer. You got the squamous cell, and then you got adenocarcinoma. Adenocarcinoma incidence is increased. So the squamous cell used to be, they thought, linked to the smoking and drinking. Now the adenocarcinoma is more from that bodily or cellular change due to increase in growth. Right. So you see more adenocarcinoma versus squamous cell now than the other. Here's the determining risk factors, right? GERD, Barrett's. Again, Barrett's presents. It's a change at the cellular level, so you'll see kind of like what did you describe it as the other day? For Barrett's, the way it presents.
Red wine stain?
Yeah, red wine stain. So you got that nice healthy pink mucosa going down the esophagus, then you get to the LES, and then it looks kind of like a red wine stain. So basically, what those cells are doing is they're changing, right? They're changing from squamous cells to, anybody know? Columnar cells, right? Columnar cells are what you have in your stomach. So literally, because of the GERD, your stomach is made to hold the acid, your esophagus isn't. So your body is literally changing its cellular formation into that, similar more to the gastric. But it's not good. It's not supposed to change like that. So that's why you get Barrett's. And then there's low-grade dysplasia, which you can do with RFA, treat it that way. And then it progresses to high-grade dysplasia, which you have to either RFA or resect through a CAP EMR. And then there is cancer in situ. So cancer 0, and then it progresses to esophageal cancer stages. Obesity, diet, achalasia, and esophageal webs, smoking and drinking, obviously, are going to increase that as well, just like every other cancer. So what do we do for it, right? So first thing, when a physician will call us and say, Matt, I need an esophageal stent, my first question is, hey, what's the treatment algorithm for this patient moving forward? Is it palliative, or is the patient getting any kind of adjuvant or neoadjuvant therapy, right? Because that makes a huge difference, and we'll go through it on the stent. So if it's palliative, right, the importance for a patient, and you all see it more than I do, the patient just wants to be able to eat, right? The basic function of being human is they want to eat before they die. They don't want to get their nutrition through a peg tube for the end of the days, whether it's 3 weeks or 3 years, right? So we can place an esophageal stent. Our stents, we put covering for a majority of the stent, but the top and bottom flares are uncovered to help with tissue epithelialization, which reduces migration. Because again, the last thing you want to do is have a stent migrate on a patient with esophageal cancer and keep bringing that patient back to retrieve it, put it in place, and have them go through more and more procedures. If it is a bridge to surgery, you know, they can get the radiation. There's studies out there that prove patients that get oral nutrition versus a peg tube nutrition during that neoadjuvant therapy actually respond a lot better. And their BMI goes up by about 0.25%. So not a huge amount, but again, being able to eat natural foods versus a peg tube makes them healthier Because what happens is if you get, for any reason, if the patient's BMI drops too low, they get too sick during the radiation therapy, they have to stop, get that patient healthy again, get their BMI and their levels up, and then they start the radiation again. So just, you drop the esophageal stent in, do the radiotherapy, and go from there. And then with a fully covered stent, during the procedure, they cut, when they go to make the resection, the stent just pulls right out. Sizes, 18, and you just need the esophagus to be up to 18. If you have a patient that is a 70-year-old lady who is 100 pounds, you do not want to put a 23 millimeter in there. There is going to be some chest discomfort because that stent's going to expand over the first 24 to 72 hours, so it's going to push that stricture out. You just don't want to have too much chest pain. If they have that kind of chest pain, bring them back, pull the stent out, place a smaller size, right? They go from 10, 12 to 15 centimeter lengths. Most strictures that I see are anywhere from about 4 to 5 centimeters in the esophagus. The rule of thumb is having 2 centimeters below. Most of the time it's right at the LES, so it goes right into the stomach, the bottom flare, and then you want to have enough above it so when it does come down, there's still enough stent above that stricture where it's not going to migrate into the stomach. And the radial force, as you all can see right there, it's pushing it out in all directions, right? So it's not just the shear force, which is kind of like, if you ever seen a bougie used, the shear force is pushing it and it goes side to side, pushes it out, kind of like a snowplow. You're pushing it in one area, it just pushes it out, piles it up to one side, versus standing in the middle, it just pushes it out evenly throughout the stricture. So this is a picture of our stent placed. Usually, this is actually probably within 30 minutes after the deployment. You can see it's almost fully open. Most of the time you'll see like an hourglass shape, and that just means the stent is right in the middle of the stricture. And then again, over the first 24 to 72 hours, it will foreshorten and push the stricture out. The way you want to do this, and we'll get into the in-service part of it now, is you can see right here they placed 2 hemostatic clips, and basically that just lets you know where the top of the stricture or where they want to place the stent, or this looks like maybe even post-deployment to make sure to reduce the migration. They clip the top parts of the stent, the top flares, to the mucosa to help with reduce the migration. Ideally, what you're going to do, figure out the size, figure out the location of the stricture, and then with the physician, go down, visualize the proximal end of the stricture. If you can get the scope through, that's great, right? Over fluoroscopy, you're just going to drive the scope past the stricture, figure out where the start of the cardi is or where the end of the stricture is, and then externally, wherever the end of that scope is, open up a paper clip, put a piece of surgical tape, and then you just tape it externally to the patient. That gives you the bottom of the stricture. Pull back the scope, visualize there, and then you can place another paper clip. This gives you a pretty accurate reading. You just take a small ruler, measure the paper clips on the outside of the patient, and then you'll understand where the stricture is. If you can't get the scope through the stricture, anybody ever worked with ERCP catheters, urology catheters, anything like that? Okay, so you want to just put a catheter with a guide wire, and usually I do 260 centimeter stiff guide wire, or you all familiar with the Savory guide wires, the nice stiff metal ones. Those usually work the best. Put the guide wire through the catheter, get it past the stricture under fluoro. If you have an extractor balloon from the GI lab, that's the best one because you can put the catheter over. It's got a radiopaque marker that you'll see right below the stricture. Blow the balloon up, inject just to make sure that you didn't go through the wall and that you're in the stomach. Pull back till you meet resistance. Deflate, and then, before you do that, at the radiopaque marker on the catheter, place the paper clip, deflate the balloon. Where the physician's got his fingers at the biopsy cap, have him hold it there, pull back until he sees the balloon catheter come out of the scope, probably up here at the proximal end. And then he's got a measurement, right? He's got a measurement of how long that stricture is. Have him put the scope in the proximal end, put the other paper clip, and you can measure it that way as well. Again, the external paper clip, or you can measure the catheter. This stent unfortunately does not go through the scope, so what you'll have to do is push the guide wire till you see it loop in the stomach, pull the scope out as the tech or the nurse is pushing the guide wire in. Before you backload this over the guide wire, just take some saline, or if you've got the sterile water right there, flush it through there to make sure it gets nice and lubed up in the internal channel. Backload it over. There's two ways you can position the patient, right? They should be probably on their back at this point, so you can see it nice and flat. Either going to want to retroflex their head, which I know actually closes off the esophagus a little bit, but it's easier for the physician to get it slid in through the patient's mouth down into position. Or they can pull their head forward, which actually opens up the esophagus, and then they'll have them bend it in, push it into the area. There's two ways. If the physician chooses to retroflex the patient's head, they're going to hold the stent out just like this over the patient's head, because again, it's going in flat. Once the markers are in place, again, there's 4 markers. There's a traveling marker, there's a distal end marker, so it'll let you know where the end of the stent is. The traveling marker, as you deploy, will come up. You'll see, and it just lets you know how much of the stent is being deployed. There's about 70% up the catheter. There's a point of no return. A point of no return means about 70% of the stent is deployed. If for whatever reason the stent is not in the right position, physician doesn't like it, you can resheath the stent, reposition it, start your deployment. And then there is a proximal marker, which will let you know where the top end of the stent is, right? So once they have that, have them hold this handle, or if they choose to bend it, they want to put the stent into their breastplate. It's nice and hard. And then this deployment piece right here, you'll just slowly pull towards you. Now, because I've deployed the stent a lot, it's very easy, but once it comes out of a package, there's a lot of tension on the stent. So it may take a little bit to start getting it going. You don't want it to jump. As the physician starts to deploy it, the stent is going to naturally want to go away from you. So as you deploy it slowly, you want to pull back, deploy a little bit, pull back, deploy a little bit, pull back. Once the stent is deployed inside the stricture, it'll cease to move forward, and you just want to slowly pull the stent and deploy it until it's fully deployed. To get this catheter out, just slowly pull the wire and the catheter out all at once. If it feels like it gets stuck a little bit at the very tip, just either spin it, twist it, or you can actually resheath it and then pull everything out. And then the physician will probably choose to take the EGD scope, go back in, make sure that the stent's fully deployed, it's in a good position. This is what it should look like over fluoroscopy. Again, probably a little bit more wasting because depending on how tight the stricture is, then the patient will be good to go. So MRI capability, for whatever reason, they have to get an MRI, they can go directly from this procedure, get an MRI. It's indicated for up to 1.5 to 3 Tesla. So the strongest MRI machine in the world, I think, is 3 Tesla. So they don't have to worry about this thing getting pulled through their chest.
That's good.
Same thing with our clips. I get that question a lot with those because of the metal. So I think that's perfect time. Okay. Anybody have any questions? All right. Well, I do appreciate your time. I know it's early in the morning, and look forward to working with you guys in the future.
Thank you.
Take care.